just so that we all know, Kevin has previous experience around the globe, working as an advisor at USAID and also as a senior advisor to the director of the Central Medical Stores in Mozambique and in other countries in the world. His core skill areas are in retail, in supply chain strategies, in implementation and monitoring evaluation. So over to you without much ado, Kevin.
Thanks so much, Kwesi, and thanks to everybody for joining. I know it's a very busy time right now, and we really appreciate all those of you who have joined us. Hopefully, I think this will be well worth your time. The topic today is a really exciting one that could potentially transform the way we provide essential health commodities in lower and middle income countries, but one which requires a lot of discussion and work to get there, and this is kind of a first step. Before I get into the specific topic today, I just wanted to first express our appreciation to the MTaPS program and the Boston University team for all your work on this paper and for the presentation today. And also to all the panelists for taking the time to join us. I know all the panelists are very busy people, so we really appreciate and look forward to your reflections. For those who don't know, MTaPS is a USAID funded program that's led by MSH and works to enable low and middle income countries to strengthen their pharmaceutical systems to ensure sustainable access to an appropriate use of essential medicines and related pharmaceutical services. They've been a great partner for this work. They bring the expertise on pharmaceutical policy, financing, medicine supply chain, and have a really great set of academic partners that we'll hear from today. So really appreciate all their work on this. Just want to take a minute to kind of talk about how we got started kind of down the road of the project that we'll speak about today. USAID and others have provided support to public sector supply chains for decades. USAID's family planning supply chain program started in the 1980s, and we've certainly seen a lot of progress in so many fronts in the supply chain area, but in many countries, we still confront the challenge of the bottom line of ensuring that there is reliable access to quality health commodities at health clinics and in communities for essential medicines, contraceptives, other program drugs. And so that has led to a lot of discussion and questions around whether the public sector serving as really the operator of the supply chain for health is the right approach and the best approach to helping us achieve health access, health commodity access for everybody, and universal health coverage. So there are a number of ways that, as a community, we've been discussing the public sector moving to potentially more of a stewardship role, where they oversee the supply chain, but don't necessarily operate the day-to-day, managing of the trucks in the warehouses. Within that, one of the more radical suggestions is to look at a model which works currently in many high-income countries, where the private sector pharmacies are the ones who are responsible for supplying the medicines to the clients and patients, at least for outpatient services. And this works even in many countries where there is a single-payer public sector healthcare system, as we see in many lower and middle-income countries. So just on a personal note, so I'll talk about my wife for a minute. She's Spanish. When I mentioned that I would talk about her, she said that I should say a beautiful Spanish woman. So just to make that clear to everybody. So my wife, Spanish, lives in Spain, goes to the public sector clinic when she has any medical issue, gets her prescription from the public sector doctor, but then she takes that prescription to her local neighborhood private sector pharmacy to fill that. And in almost every case, they fill that prescription on demand in a few minutes, and she only pays a small fee because most of the cost is subsidized by the public health service. So the question is, could that model, which works in much of Europe and many other countries, work in many of the lower and middle income countries that we support? And so that's kind of where we got started with this. We know that there will be a lot of challenges and requirements for such a model to work in lower and middle income countries. But we think that there's a need to start that conversation, to begin the conversation about what can be done. Is that a direction that we could potentially go in to increase access to essential medicines? So we asked MTaPS and Boston University to begin some rigorous thinking and analysis around that topic. Could such a system work in LMIC health systems? What would the benefits be? What would the challenges be? What would be the requirements of such a shift? And so this thought leadership paper that we'll discuss today and we'll share the link for later is really a first step in just getting the conversation started, providing some evidence and thinking to explore the implications of such an approach while we seek to improve the availability of essential health products and universal health coverage. So that's what the conversation today is about. It's just, again, a first step, but an important step on that journey. In addition to wanting to share the results of the paper and the study with you all, we also want to hear from you. We want to hear your thoughts about the countries you work in. Will this work? What would the challenges be? What are the best opportunities? What are the contexts where it might work best? So we look forward to hearing your thoughts on all of those things and on the results of the study. So with that, I'll hand it back to Kwesi. Thanks so much, Kwesi, for your leadership on this activity, and let you move us forward. Thank you.
Thank you, Kevin. It's been a very fruitful 1 year working with you and the Boston team, to come up with this paper. So we have 3 wonderful speakers, will be taking us through the highlights of the thought leadership paper and also highlighting the pros and cons and challenges. We have Carlotta Cellini, who is a research fellow with the Department of Global Health at the Boston University, School of Public Health. Carlotta has been very instrumental in putting together what we've done. Prior to joining the Boston University, her work has spanned both the pharmaceutical industry and a number of NGOs, in a very unique perspective of helping to translate research with practical, metrics to ensure, innovations reach the people who need it. We also have Professor Warren Kaplan, who is a clinical assistant professor with the same Department of Global Health at the Boston University. Warren comes to this with a lot of experience in the legal and access environment. He has worked with many institutions, including the Boston University, as a general counsel at Biogen in Cambridge, and also been able to support and work with the Doctors Without Borders and the Clinic Foundation. It's been a pleasure working with Warren. And then also Professor Veronica Waits, who most of you may know, has been involved with the Lancet Commission. She's a professor of global health, at Boston University, School of Public Health, where she's also a director of the World Health Organization Collaborating Center in Pharmaceutical Policy. So without much ado, I'll hand it over to the Boston team led by Veronica to share with us the findings and their thoughts around this all-important area of initiating the discussion around how we can involve the private sector pharmacies in LMICs. Over to you.
Okay, great. Thank you everyone for joining us today. It's really our pleasure to present today to a very wide audience the findings of our paper, the use of retail pharmacy as a source of essential medicines, including family planning products for public sector clients in low and middle income countries. You'll see on the slide just a direct link to the paper if you're interested in reading the full paper, but just as a bit of an introduction, this is a project which my team at Boston University, which includes, as mentioned by Kwesi, Dr. Roberts and Dr. Kaplan, have worked on over the last year in collaboration with MTaPS. And so I'll start the presentation off by going over some background, which serves a bit as a rationale for this project, and also go over the project aim, the objectives, and a quick overview of the methods before I hand it over to Warren for an overview of the results. So just for some background, retail pharmacies are an important part of health systems in that they dispense really large portions of all health products and related services to patients. They offer very convenient opening hours, geographic accessibility, and personal familiarity with their clients. And so for the clients or the patients, the added value of these advantages is that they may translate into financial savings and therefore also improve retention and care. So in a way, they're a patient's first port of call with the health system. And so because of that, they're put at the forefront of a potential role in expanding access to medicines. Now, in high income countries that operate an open medicine dispensing model, pharmacies have been contracted in the past by public or private insurance schemes to dispense medicines to outpatients in the community. By contrast, dispensing of medicines in low middle income countries is often organized using a closed model, so in which institutions or organizations in charge of financing medicine dispense the medicines themselves. However, most countries that USAID supports that operate this type of closed model face many barriers in terms of investment in supply chain, which makes it very challenging to ensure continuous availability of specific products such as contraceptives and just in general of essential health products. So it is quite in light of these issues that retail pharmacies have been recognized as important partners in expanding services that are otherwise traditionally provided by the public sector. And this open model dispensing should be of particular interest for countries that are moving towards universal health coverage and the implementation of insurance and other medicine benefit schemes. Next slide, please. And so with that in mind, my team at BU's aim with this project was to produce a thought leadership paper, which would present how public payers can engage with the private retail pharmacy sector to efficiently deliver essential medicines, including family planning products, to public sector clients in low and middle income countries. So with USAID, we agreed on two main objectives for this project, which were one, to identify the advantages and disadvantages of this type of contracting model. And number two, to describe promising policies and strategies for public payers that are considering the implementation of such a contract with the private sector. Next slide, please. So I'm just going to go over a little bit of the methods because I think that understanding how this work came to be will provide some important context and help us understand the value of this research, as well as how we can use those findings and how to learn from this work. So this is just a bit of an overview of all the steps that we employed to get to where we are now. I will not go through them all in detail, but you can always refer to the full report for more details. But as you can see, this is an extensive step-intensive work, which started back in March 2021 and went on until the end of January of this year. Next slide, please. So contracting with retail pharmacies offer benefits to public payer. However, the contracted private sector can have diverging interests that can jeopardize the values and goals of the public payer. So for us to understand whether a contracting model would really help address accessibility, it was really important to understand the context of the contracting model. And so to do so, we came up with a framework, which is composed of the 7 key dimensions that are outlined on the slide. And we did so by adapting 2 key works in the field. The first one was a 2017 review by the WHO on partnering with the private sector to strengthen provision of contraception. And the second one was a literature review on the challenges related to public-private partnership and health in sub-Saharan Africa. And this work was conducted in 2012 by actually my colleague, Dr. Warren Kaplan, who's here present today. And then in order to answer objectives, the next step included assessing the experiences of different countries with varying levels of experience with contracting private pharmacies. So we decided to select some case studies and assess each of these case studies experiences related to each dimension that we outlined in the framework that I showed on the previous slide. So sort of to understand what works and what doesn't work. So for the case studies, we were interested in selecting high income countries and low middle income countries, so a mix of experiences with public payers contracting retail pharmacies. You'll see on the slide the selection criteria. And given the selection criteria, our final selection included 3 high income countries, Spain, Sweden, and the UK, and then 4 low middle income countries, Argentina, Brazil, Ghana, and Namibia. Next slide, please. And then we agreed with the USAID that given the resources, we'd be conducting a scoping review rather than systematic literature review. We conducted the literature search primarily on PubMed, Google Scholar, and CINAHL. Again, you'll see the inclusion criteria on the slide. And then I will mention that we did obtain quite a bit of additional relevant sources outside of the case studies really just to augment specific issues that were identified by our reviewers, and also to just eventually redact the full report. Next slide. So as I mentioned, the first piece of writing and the most important one was the case studies. They were really instrumental to the development of the rest of the report. And just to give you a bit of an overview, again, these are available in the report. We structured those in two parts. The first was just an overview of how the retail pharmacies are contracted in said country. And we guided it around 4 main questions, which outlined how they're chosen by the public sector, what services they offer, how they're paid, and also how they're accredited, regulated, monitored, etc. And the second part was really where we assess them according to our framework. So again, according to, affordability, accessibility, quality of care, etc. And I will mention also that we went through a lot of rounds of reviews. So we had some external reviewers, also external USAID reviewers, and just a total overall of 5 reviews. So we really were trying to capture a very complete picture. And just very quickly, before I hand it over to my colleague Warren, I'll just give 2 sort of disclaimers. So while this work did involve external experts in a role of reviewers, it did not include key informant interviews. So it really focuses on the existing literature on this topic. So that's where, maybe future work would have to include a consultation of specific experts in this area to complement our work. And I would also like to highlight again that the outcome of this work is a thought leadership paper and not a manual or how-to guide. So as Kevin said in his introduction, this is really a first step in identifying policies and strategy that are really heavily context dependent. And so each country interested in contracting with private retail pharmacies should really carefully consider each of these strategies and decide whether they might be applicable to their specific country context. All right, I'll hand it over to Warren, who will walk us through the findings.
Thanks, Carlotta. So I'll talk about the results. The next slide, that's, by the way, probably the simplest slide you'll see here. So this is just an overview of essentially what Carlotta had mentioned. The 7 countries, just to repeat again: 3 high-income countries, Spain, Sweden, and the UK, and 4 low and middle-income countries, Argentina, Brazil, Ghana, and Namibia. We've created a final report, and you can see some statistics about the size of the final report and how many country experts and so on. Next slide. So let me get into the meat of this. Clearly, as Carlotta mentioned, the provision of services depends on the willingness and the capacity of the contractors to offer the service, and maybe it's obvious, or the appropriateness of the service, and this is largely context dependent. So what I'm going to summarize here are the most frequently mentioned in the literature overarching advantages and disadvantages of public sector outsourcing to the private sector. And you can see some of these advantages, some of these examples. I don't have to read every one of these, but you can clearly leverage private sector capabilities through the business acumen of the private sector, supply chains, private sector IT. Every country will be different, diversified talent pool, and so on. I mean, typically, although it's not always the case, public sector organizations have more formal, maybe less flexible, and more risk-averse decision-making procedures than do their counterparts in the private sector, because the public sector tends to be designed around, I would say, a bureaucratic model, put it in quotes. But public sector organizations can, in principle, be more willing to introduce dramatic changes because they don't fear losing market share, unlike the private sector. So our report focuses on the public payer perspective, but it's relevant to mention actually that there are advantages for the private sector, for private pharmacies, to engage in contracting with the public payer. For example, as one example, you have an opportunity, or the private sector has an opportunity to increase their client pool, which can subsequently result in higher profits. So it's a really important way of thinking about both of these entities that have different agendas in part. And the trick to develop a good public-private partnership is to actually think about the balancing of that. And I'll talk about that in a second. So again, these are summarizing some of the main advantages of public payers contracting with private pharmacies. Let's go to the next slide. And this summarizes some of what the literature has said about the disadvantages of that. And you can read it. It's costly for the public payer to oversee and audit the entities that they're contracting with. There are issues of quality. I want to talk a little bit, not much, about this third bullet point. When public and private entities in a given country do an analysis of the geographic distribution and size of the pharmacy sector, and whether it's a chain or independent private pharmacy sector, and the capacity of the public payer, it's really important to consider equity issues and geographic distribution. I'll give you an example. In Spain, and Kevin would have to back me up, the equity and access to pharmacies seems to be better achieved by establishing, I would say, demographic or needs-based criteria to open new pharmacies, including, I'm not a Spanish speaker, farmacia botequín, which are pharmacy outlets in rural areas. In other words, where pharmacy services are provided by one of the pharmacies in the nearer town or village. And among these nearby pharmacies, one of them is designated as this botequín, and this one will be the only one eligible to cater to that part of the population that's geographically isolated. In principle, pharmacies in rural areas and low and middle income countries could be able to join together to benefit from joint deliveries to their community. So that bullet point in particular is interesting and important in terms of equity of distribution of medicines and the geographic perspective. As for the dimension of governance, generally, what's really needed is a detailed situational analysis of the pharmacy and supply chain sector, including human resources. And we think that's critical. And the next slides will sort of summarize that. But again, this is an overview of some of the disadvantages of having this public-private relationship. Okay, next slide. So here's this fancy slide. So I guess the key is when designing a contract, it's absolutely critical to understand the attitudes of the stakeholders. And these stakeholders, people understand exactly what I'm talking about. Governmental ministries, regulatory agencies, price control boards, if countries have them. Understanding the rules and the roles of the stakeholders and engaging them in a dialogue and in making decisions is really critical, as it can help facilitate mutually beneficial partnerships between the payer and the pharmacies. Maybe I think everyone should understand that it's really important to get all the relevant stakeholders involved if folks are serious about creating this relationship. And the next slides are going to provide some guidance as to which aspects should be considered, again, from the literature and from our review, should be considered when deciding whether or not to create this contractual relationship. Okay, next slide, please. So here's this table. The key considerations, the left-hand column are some of the dimensions that we describe in more detail, for sure, in more detail in the paper, the governance, the contracting and reimbursement, the IT management systems, which is a very interesting subject, the quality of care, financing, accessibility, and patient-centered pharmaceutical care. And I'll talk a little bit about each one of those in subsequent slides. Let me just mention about accessibility. It's certainly possible that low and middle-income governments would consider contracting retail pharmacies. If they can, that could lower the barriers of entry of pharmacies in rural areas by outsourcing their operation to private providers in rural areas. And Spain is a good example. Whether or not that can happen in another country or in a low and middle country, that's clearly context dependent. But that, for example, that provision of in rural areas to enable private providers to provide services, it's likely to fail if the resulting business is not incentivized to initiate operations in the first place. In other words, it's a really difficult balancing act between creating, for specifically, pharmacies in rural areas and having them be sustainable, having the private sector be financially enabled to continue operations. So that, for us, is really important to consider. But it's the key, I think, to understanding how public payers can effectively enter into contractual relationships with private sector retail pharmacies, the balance between provision or letting the private sector enable development of a system to provide medicines, and having the private sector be sustainable and making a profit. This highlights the importance of low and middle income country governments interested in doing this contracting to do a thorough situational analysis and devise appropriate policies to create some context in which the private sector can sustain itself. So I guess another way of saying it is this relationship has to be seen within the entire health, I guess, financial and business ecosystem. So it really needs to be from a systems point of view. And specifically, for example, in Brazil and Ghana, what's interesting about them is that public payers had to make a series of, I would say, adjustments over time, over more than 10 years, to calibrate the strategies going forward as time moved on. So this requires sort of recalibrating roles and accountability over time and changing circumstances. That will happen. And so that needs to be taken into account. Let's go to the next slide. There's some key strategies, and this is just an overview of, there's 4 red boxes there. And so I'll talk briefly about each one of those. Let me go to the next slide. We might as well keep moving on. So there's contract. These are the strategies, contract-based business incentives. And you can see the bullet points there. I won't read every one, but the point is that there needs to be financial incentives for the private sector to participate. And the incentives should be built into the contract, not sort of created over time and thrown in. They should be thought about initially, right at the very beginning. For example, in Ghana, the National Health Insurance Scheme, one of the issues there was that the reimbursement prices were lower than the patient prices. And private pharmacies took a loss. So that's an example of sort of a lack of financial incentives, or not entirely thinking through the consequences, both intended and unintended consequences. Similarly, in Brazil, after lowering the amount of reimbursement that retail pharmacies were paid that took part in the private part of Farmácia Popular in 2018, private pharmacies were less attracted to enroll in the program. So the contract-based initiatives have to at least include some sort of financial incentive for the private sector to participate. That's absolutely crucial. And I won't go through the other bullet points, but you can see that. Providing startup capital, support from local service administrative organizations to manage pharmacy operations. Okay, next slide. This is another consideration is governance. And part of the governance framework is an accreditation process for pharmacies. So in principle, that should be part of the contract too, or part of the agreement with the public payer to build in accreditation for the private sector. And it would be ethically, from my point of view, it would be difficult to defend any public payer who's contracting retail pharmacies without the public payer also promoting product and service quality and preventing fraud. So governance needs to include accreditation. That second bullet point about information technology solutions, for sure, European countries have contracted private pharmacies for decades. and IT systems have many, many years to mature. But low and middle income countries, and clearly there are people in the audience who know far more about this than I do, they haven't yet necessarily at a large scale developed the IT capacity to enable dispensing, verification, invoicing, payment. All those things are critical to efficiently contracting services. In Brazil, there was a weak IT system for the tracking of medicines, for example. So it was difficult to avoid issues like fraud and illegal commodities, and this eventually contributed to the Pharmacia Popular having problems. That's probably, let's go to the next slide. And here's another strategy or another thing to think about is the supply chains. And there are several bullet points here. So what's needed are specific market studies. This is a big job to actually do this. There are interesting innovations that have emerged. An example of group purchasing and inventory management comes from Kenya. The first commercial group purchasing organization, what was it? MedSource was introduced in 2017 by Management Sciences for Health. And in principle, MedSource should allow its member pharmacies and pharmacy chains to buy medicines at better prices than would otherwise be available to them. There's interesting considerations to look at the distinction between chain and independent pharmacies. Clearly, I shouldn't say clearly, but when a government chooses to contract with a pharmacy chain rather than dealing with multiple companies, the advantage is that it deals with only a single administrative body that covers many pharmacies. In principle, by decreasing administrative costs and streamlining it, this chain pharmacy contracting model should be less expensive than multiple contracting and might be easy to monitor, particularly for quality assurance and other regulatory issues. In some low and middle income countries, contracting with pharmacy chains would offer an opportunity to address issues of fragmentation in retailing, poor quality monitoring, and high prices. So that's a possibility. Pharmacy chains may need to centralize their dispensing within their own networks. For example, in the United Kingdom, some pharmacy chains that keep getting repeat prescriptions are connected to a regional centralized dispensing entity. The difference is that independent pharmacies who aren't part of a chain may need to rely on wholesalers to deliver central dispensing services, or even maybe develop a cooperative model within the independent pharmacies as some sort of joint partnership model, if wholesalers are not going to assist in that. So lots of things to consider. Let's do the next slide. Human resources, that's a really important issue. The availability of HR is a key factor in ensuring that contracts with private pharmacies support access. At the same time, a contracting out agreement that leads to efficiency and improvement should not be undertaken at the expense of human resources in the public sector. So for a successful shift to doing some sort of contracting out model, countries need to think through the implications related to the loss of jobs in the public sector if that's going to happen. For instance, a strategy might be to develop human resource capacity in the public sector to manage the agreements. But countries need to think about what happens when folks might leave the public sector to join the private sector in this contracting arrangement. There's a bullet point about task sharing, and I'll quickly go through that. As you know, injectable contraceptives have to be administered and often provided in health facilities, but many client-initiated forms of contraception, for example, diaphragms, oral contraceptives, can be provided in retail pharmacies. So task sharing, by task sharing, we mean maybe allowing community health extension workers or pharmacy staff to actually administer injectables. But that's a big job. That requires all manner of other considerations. The last bullet point, and before I turn it over to Professor Wirtz is this business about patient-centered approach to service delivery at pharmacies. In high-income countries, over the last 5 or 6 years, there's been a growing recognition that moving toward patient-centered pharmacy services holds a lot of potential for improving access to services. We found a really interesting example in Sweden. It's a pilot program. What they're attempting to do is develop clinical counseling by community pharmacies. And that's been something that's happening in Europe. Whether or not that can happen in a low and middle income country as part of this human resource shift to the private sector, we'll see. But that's certainly countries, richer countries are thinking about dropping down the clinical approach into community pharmacies. So that's something to think about. Okay, I will now turn it over to Professor Wirtz, who will finish off this presentation.
Thank you very much, Warren. And I would like to just remind the audience that we, in addition to the opportunities that Warren highlighted, we also discussed in the document challenges when contracting retail pharmacies. Warren already alluded to many of those. So I will jump ahead a few slides to the challenges that we encountered regarding the pandemic, and that the pandemic actually pointed to important kind of considerations when contracting private pharmacies. So it's really essential when we discuss today the topic of contracting private pharmacies by public payers to see that in the broader context of health systems strengthening and the current pandemic. The pandemic has brought huge challenges to health systems, including disruption of medicines and vaccine delivery. And that has forced public payers to rethink the delivery of their service, including through pharmacies. So the first kind of, let's say, point that was brought up by the pandemic really upfront is increasing the demand for pharmacies to deliver medicines via courier services to people's home or close to people's home. And this means contracting pharmacies with the capacity to extend the last mile. There's also a second observation that our results show looking at the pandemic and its effects is decoupling the services of the product delivery from the service delivery. What does this mean? That means that there is a potential for greater efficiency, potentially for delivering services. For instance, less investment in training of thousands of pharmacy staffs in retail pharmacies if there can be a center that can deliver virtual or online services, counseling services, and the products would be delivered via courier much closer to patients' home. Many governments have made use of that, and including in low and middle income countries, centralizing delivery and sending that out closer to patients' home. Then the third point that we identified as important is thinking about tailoring pharmacy services according to the specific population that is targeted and that needs those services. This means that the public payer should carefully need to identify the target population in terms of their needs. Would, for instance, virtual delivery of counseling address those needs of the population? Or are we talking about a population that requires in-service and demands that service? That allows the public payer to much better target that population with the adequate contracting of such services. Expanding the role of pharmacies to deliver primary care services has been another topic that the pandemic has brought up. That means increasing, and also this means increasing the delivery of health information that can be trusted. So during the pandemic, many public payers have been very intentionally contracting retail pharmacies. I see also some comments in the chat about that, for delivering, for instance, vaccines plus trusted health information. The UK has been an example of contracting, for instance, pharmacies to deliver vaccines, and also in the chat, some of the audience already contributed examples to that. So all in all, this means the pandemic has brought up important lessons learned from how public payers can be much more intentionally contracting private services, and this also has an implication on the topic that we are discussing today. So let me go to the last slide, which I would like to conclude that a brief presentation about our report. Next slide, please. So before closing, a few final reflection on what has been presented by Carlotta, Warren, and myself about the report. In many countries, the public sector supply of medicine has suffered from chronic underfunding, stockouts, long wait times, and inconvenient opening hours, and low user satisfaction. And many countries want to assume, many countries at the moment have large donor support to run the distribution chains. And unless these countries want to assume the cost of maintaining such large and separate supply chains, they might want to think about transferring such distributions to retail pharmacies. And this transfer comes with benefits and costs, and the report provides some input into the thinking, what are the benefits and what are the costs in a specific context. So the public payer must have the capacity to develop, implement, and enforce contracts of private pharmacies, and in some cases that will require, as the report points out, changes in the legal framework that underpins both public and private entities, including public payer and retail pharmacies, that also might require changes in the management of professional associations in their role of overseeing retail pharmacies and their role in overseeing individual professional standards. So it's essential for countries to very carefully assess whether an engagement of the public payer with retail pharmacies is feasible to begin with, and also the right fit for the country context and the target population that should benefit from such services. The report provides guidance to governments, donors, and other stakeholders in this assessment of the situation. If a country decides to develop, implement, and contract retail pharmacies, they will have to invest in the evaluation of such contracting models and then readjust their contracting models based on the results of such evaluations. So at the end, we want to leave the slide of the acknowledgements of all the people that have contributed to the report. And with this, I hand back to Kwesi. Thank you very much.
Thank you very much, Carlotta, Professor Warren, and Veronica Witz for the great presentation and the summary of the thought leadership paper. I think based on the comments so far in the chat, this is a very topical issue, and the considerations that you laid out sort of spells out what countries need to look at if we want to contract out the services to the private pharmacies. So thank you so much for that. A couple of years back, when I was talking about this topic, a lot of people were like, do you really want to contract out services to pharmacies? So we decided to have an audience poll just to find out what our audience think. So my colleague Rajita is going to share a poll that will briefly, in the next 30 seconds, I'm going to ask all our audience to vote. Do you think that contracting of retail pharmacies is relevant for countries moving towards universal health coverage? This is just a single survey, single choice survey. And for the next 30 seconds, I would like to encourage all our participants to vote, based on where you sit and what your perception of all this is. Over to you all. It's a simple yes or no. Do you think that contracting of retail pharmacies is relevant for countries moving towards universal health coverage? We have 30 seconds. I think we're almost at the end of the poll. Okay, so Rajita, I think we are done.
Yes.
Seconds. Yep. Are we
I'll
good?
end the poll and share the results.
Okay. So from the results, it appears almost 97% of our audience think that's a good way to go. And just under 3% think that will not be a smart idea. So it looks like an overwhelming, recommendation to go forward with that. And as Kevin said at the beginning, this is the beginning of conversations to see how best we can move forward with this idea. So as a next, thank you audience, thank you so much for your participation. As a next step, I would like to actually move to a panel discussion where we have three very knowledgeable individuals who have agreed to serve as a panel to give us some insights of their view, relative to this topic. First, we have Professor Zahir Uddin Baba, who is a professor at the Department of Pharmacy in the University of Huddersfield in the UK, and also the editor-in-chief of the BMC Journal of Pharmaceutical Policy and Practice. So welcome, Professor Baba. We also have on the panel Ms. Denise Harrison, who is a senior market development advisor for the Office of Population and Reproductive Health. It's Commodity Securities and Logistics Division of USAID. Denise, has been working in support of the private sector and as an advisor of USAID, supporting the Division of Commodities and Securities Logistics in Washington, DC. Denise has published widely and it's also had one of her documentaries published in the Journal of Contraception and in 2006. Denise has been very supportive with this work and very knowledgeable in this space. So welcome, Denise. We also have Denise Okidi, who is the Director of Supply Chain of the USAID Strengthening Supply Chain Systems activity based in Uganda. Denise, is new to the project and just joined and has agreed to give us an overview of the experiences that they've also had in Uganda relative to this. So I'd like to welcome our three panelists. And first to start with Professor Baba. In the next 5 minutes, I would love to hear from you, what is your general thoughts and overview of this area of work as a professor of pharmacy. Over to you, Professor Baba.
Yeah, thank you very much. I think overall, this has been a fantastic piece of work. I've been involved in reviewing the report. And from my point of view, it has strengths, for example, that this is the first time, a study has been conducted, which is actually looking at a cross-section of countries, which are low-income countries, middle-income countries, and high-income countries. Normally, we didn't really see these sort of studies in high-income countries. So we have Sweden and Spain and United Kingdom. Then there is a spectrum of middle-income countries. So for example, Brazil and Argentina, and then low-income countries as well. So from that point of view, I think it's quite interesting. The second major point is that looking from the giving and contracting the services to private pharmacies for these products, this is quite unique and challenging. But again, this is a good attempt in this regard and an excellent analysis for some of the barriers and challenges which have been pointed out in the report. I would like to state some of the key points where I think that the health system overall needs to be strengthening, because some of these challenges, if the policy implication need to be implemented, then the health system needs to be strengthening. For example, if we talk about quality of products, then of course, in high-income countries, they are already good quality because of the strong regulation in these countries, whereas the quality of products may have challenges in some of the countries where the regulatory authorities may not be so strong. So some issues the report has pointed out in the right direction, but I think they're linked with the strengthening of the health system overall, as far as the quality of the products is concerned. Another important point which is being highlighted in the report is related to information technology and how information technology can help to improve pharmacy services or to improve access to products as well. And that's again linked to the health IT within a country. Because if you look at high income countries, for example, Spain or Sweden or United Kingdom, the whole health infrastructure, IT infrastructure is being upgraded. And so as the pharmacy and pharmaceuticals and quality of pharmacy services is linked to that. So we can't really say that we would like to update or upgrade the pharmacy services and link to IT in a low-income countries, whereas the other health setup is not being upgraded. So I think there are some central issues as far as the quality of pharmacies is concerned, quality of pharmaceuticals is concerned, or IT is concerned. But there are some excellent points which are being made in the report, that what are the challenges or barriers to support how private pharmacies could actually make a more interesting point. And we have seen that more so in pandemic, where the private pharmacies have actually gone out and they've been providing services to the patients and consumers within their homes and so on. So there are a lot of lessons to learn. This is, again, I would say, this is a very unique area, a very challenging area. And to cover up and sum up everything in a 3 different spectrum, low, middle, and high, I think that was the greatest challenge for the authors. And I must say that the authors have done an excellent job in this context, because it's not an easy job to provide generic solutions to the problems we face. Sorry, can't hear you.
Yeah, thank you very much, Professor Baba. I'll certainly come back to you with a couple of questions, but the thoughts are well taken and great points that you've made. I'd like to move on to our other panelists, Denise Harrison. And Denise, I mean, you've seen the documents and also been part of the conceptualization. I just wanted to spend some time telling us a little bit of what your insights are, an overview of the key takeaway points that you think came out of this work.
Thank you so much, and good morning, good afternoon, everyone. I'll be brief on this question. And from my point of view, I think a key takeaway is that it's really important to start supporting ministries of health, and from the USAID point of view, missions, and implementing some of these models and activities, and learning from one another. Some countries have already started contracting out to pharmacies, so it's important to learn from them. So I think moving to the implementation part is important. The point is well taken that this is kind of a first step, but I do think it's happening, and I do think by applying the lessons learned from this paper and from what's already happening out there, we can get this started where it makes sense. As we've seen from the pandemic, you want this in place so that you can support your population. So if this is the path that both the Ministry of Health and the mission is looking at. Thank you. Over.
No, thank you very much, Denise. So just as a first round, Dennis, you're basically supporting a current program in Uganda. Could you spend a few minutes telling us about the general experiences working with the private pharmacies in Uganda from where you sit? Over to you, Dennis.
Thank you. Thank you, Kwesi, and thank you everyone for being on the call. So in Uganda, I would say the contracting of provision of medicines to the public, to the retail pharmacies has just started, not really in terms of regulation, but in terms of the practice. What we have seen as part of the differentiated service delivery model implementation for the ART program is that the Ministry of Health is beginning to expand access to ART for stable clients to the community pharmacies, basically providing for ease of refills, but also more importantly, flexibility of the service hours. What has so far been done is that there's been a process to establish a system that allows for this process to link up with the public facility that does distribution of these commodities to the private sector pharmacies. And this is a work in progress. We have about close to 50 pharmacies now providing these services to clients. And what is so far happening is that given that there's no regulation for direct reimbursement of some of these costs from government, the donors are picking it up. Currently for the ART program, we see a reimbursement cost for the service of about $0.6 per patient. And so this is an area of concern in terms of sustainability if the regulations don't come in quite quickly. The other, of course, is provision of subsidized commodities like family planning commodities like condoms, malaria commodities are also being provided through a total market approach from the pharmacies. And this is happening, but this, of course, given that it's not a cost commodity and the lack of regulation, we see quite a bit of challenges in terms of the price markups that the pharmacies do put on these products. So there are issues around, we urgently need now to put in place the regulations to kind of move beyond the donor support for the ART and the rest of the services. These would also, in terms of regulation, address the price control issue. What I see as another challenge is the issue of poor purchasing practices from the retail pharmacies that then, of course, boils down to really small purchases, expensive procurements, and potentially medicines being more expensive than when provided in the public sector. And of course, given that most of these retail pharmacies don't really have quality assurance protocols that are well developed, the entry of counterfeits becomes a bit of a challenge in that light. And of course, the issue of rural communities being really underserved still stands out for the private sector pharmacies. And HR outside of the major metropolitan areas is still a challenge. So I think the experience is that we are beginning the process, really kind of driven by donors at this point. It's working well. Systems are being set, electronic systems that make sure there's visibility throughout the supply chain up to the retail pharmacy, as well as, of course, the cost reimbursement that is currently being picked by donors. So, Kwesi, that's the experience I can share and the challenges. Thank you very much.
Sure. No, thank you so much. Thank you, all three of you. You've highlighted key issues around IT. You've highlighted issues on the overall system strengthening. You've also talked about sustainability, of all this. I mean, you cannot have donors funding this all the times. And then Denise talked about the implementation. I'd just like to throw a question to you, Professor Barber. The presentation and the thought leadership paper talked about quality in terms of pharmaceutical products, which you also highlighted, and also related to the services. Being a professor of pharmacy and looking at the outputs from the schools, my question for you really is what if you assess the current trainings and the skills, in the pharmacies right now, what potentially are some interventions or new things that are being done from the outputs, the input side where products are coming out to reduce the challenges related to quality of products and services?
Thank you. I think it's a very important question. And as I said earlier on, we need to differentiate between these two, the quality of pharmacy services as well as the quality of pharmaceuticals. So the quality of pharmaceuticals, I think, it has to do with the national regulatory authority, and we can't really do anything as far as the country's regulatory authority is concerned. The next point is quality of pharmacy services. And I think pharmacy services would again depend from one country to another country. And if you look at high income countries, where some of these countries are listed here, they have reimbursement or payment models in place. So if you have a payment model in place, then of course the quality of pharmacy service could differ. That's one point. The second point, that how would you actually define a pharmacy service in a country? That's another question, because in some countries, simple dispensing or patient counseling is not classed as a pharmacy service, whereas other countries, it's classed as a sort of a pharmacy service. One of the biggest challenges you have in developing countries, and the difference between high income and developing, is that in high income countries, the pharmacy practice, what we call it, is linked with the curriculum is linked with that. Whereas in low income countries, you have more a curriculum which is going towards patient-oriented curriculum. But the pharmacy services, especially in community pharmacy setting, I'm not talking about hospitals, community pharmacy setting, there is a mismatch. So sometimes the people have sort of training, but they do not have the support system in place where they could actually sort of, practice these things. And why can't they practice? That's again linked to the regulations within the country, because some of the low-income countries, they could have multiple categories of pharmacists, where the graduate pharmacists are actually equal to diploma pharmacists, though they might not be able to sort of practice. So your question have lots of ifs and buts. So if one needs to practice in a specific country, the pharmacy, then what are the ifs and buts in place? Number one, the pharmaceutical system is supporting the person. Number two, the person is appropriately paid. Number three, if there is a program in place. So for example, you're saying that a specialized HIV program in place, which is actually providing counseling service to the patient, then there is a leeway for the pharmacist to support them. And then perhaps on top of that, what you asked me about the curriculum and things, I personally think that it's not so much curriculum which is actually driving the whole thing. It's basically up to what extent pharmacist existing knowledge and the skills are being used. So maybe a little bit skill improvement or curriculum, but more so I would call enabling factors, which could help and enable pharmacists to deliver what they already know. I hope I've answered.
Yeah. So basically, it's not just curriculum, but the knowledge that the pharmacists have already, how that can be enabled to be deployed. No, yeah.
Exactly. This is what it is.
Thank you very much.
Thank you.
Denise, you talked about implementation, and the paper also talked about the various contracting models. I think we've also had some points about sustainability. The question I have for you is that, do you think that bilateral organizations, of course, USAID, the ADB, Gates Foundation, Asia Development Bank, and others, could play any role, in supporting the contracting of private pharmacies, especially for the public payers to contract private pharmacies, or to even help evaluate these models, as a next step? What do you think is the role of these organizations, in this space?
Yes, thank you. Yes, I think these institutions would be good at evaluating contracting mechanisms or models between governments and payers and pharmacies. The development banks facilitate policy discussions and offer technical assistance. The Gates Foundation sees itself as being able to bring together the best from both public and private sectors, seeing gaps in spaces where people don't get what they need to live healthy lives because the two sectors aren't interacting well together. As for USAID, monitoring and evaluation and health system strengthening are areas where USAID has a solid track record of providing technical assistance. I think also it's important to consider consulting firms, including large international ones that offer management consulting, which focuses on providing solutions and strategies it would be important to select a firm with a local office that has strong local expertise in healthcare contracts, including contracts between public and private sectors. These firms include, but definitely not limited to, McKinsey, PwC, and Deloitte. These companies have offices worldwide, including sub-Saharan Africa. Deloitte has 12 offices in Africa, and McKinsey 6. Consulting firms build their expertise through many client engagements in the same area, which requires substantial ongoing research using big data and more, and constant collecting and using data. They advise a lot of clients, have seen a lot of public-private contracts, and they've seen a lot of various payer models. Certain firms have very deep expertise in healthcare and pharmacy management. Also, I just want to say in terms of looking at promising technologies that can support public payer in this oversight of the private pharmacy contract, I think NFTs, non-fungible tokens, and blockchain are the most promising technologies. Blockchain can enable more transparent and accurate end-to-end tracking in the supply chain. It's transparent, decentralized with a single ledger. Blockchain can help ensure that there is reliable data and a single reliable version of truth. So this, over the next 7 years, it's predicted that this industry is estimated to undergo, 70% compound annual growth. Many people in LMICs, including Africa, see a lot of promise in these technologies, which they feel can fix broken systems in the region. Very recently, a lot of you may know that the Ethiopian government signed a deal to create a national database of student and teacher IDs, which is the largest blockchain deal by a government. Thank you. Over.
Right. No, thank you. So basically, beyond donors, you're looking at reutilizing a lot of homegrown solutions, Africa-based or LMIC-based consulting firms that can help do that. And of course, that is also in line with the whole push towards domestic resource mobilization and others. And thanks for the inputs on the technology front. I think many countries are also going the route of digitalization, and that could facilitate this kind of work. So at this stage, I'm going to be opening the floor for questions, and just come back to all of you with a second round of questions if we have time. So we do have questions already from participants, and I'm going to be working with my colleagues to have that addressed. But whilst we are at Veronica, Professor Waits, just a question to you actually. You talked about the inflexibility and the challenges around adapting, long-term contracts for pharmacies. I was just wondering if you could throw some more light, if you could elaborate a little bit more on how the public payers, would enhance their capacity to be able to contract with private pharmacies.
Yeah, thank you very much for bringing me into the discussion. And I see that so many of the participants have also contributed to this discussion in the chat. I would like to thank everybody to contribute. And this, I think, shows how timely the topic is. In terms of the contracting of private pharmacies, and many of the participants also commented about this, how can the public sector be smart, efficient in doing so? And one point that was brought up, and which I would like to echo from some of the participants in this webinar, is saying, what about third parties? What about having third parties helping to monitor, standards about quality of services, for instance? We have talked a little bit about the relevance of ensuring the quality of the products that are provided. But in terms, obviously, of enforcing contracts, as the report highlights, what about the quality assurance of the services that are rendered? And therefore, third parties can have a role in this, and can play a role in it, and can help monitor and ensure the service quality in these pharmacies. New technologies can certainly also help in the service, in ensuring service quality. So one point that hasn't been brought up, but I would like to bring it up, is the increasing use of electronic prescriptions, which are then submitted to the pharmacies then dispenses these services. So the submission of electronic documents can then help also the public payers to review the services that were rendered and increase the efficiency of doing so. So how many prescriptions, for instance, were filled, what products were then dispensed. So a certain verification and then also certain evaluation of services can take place in a much more efficient way. So these are some examples, Kwesi, and I see there are also some other participants contributed with more examples in the chat.
No, thank you very much, Professor Ritz. So just to all the five of you, all the four of you, there's a point about, the HR capability at a community pharmacy. So I think Professor Babak highlighted that a bit. Aside from training, are there any insights perhaps on hiring requirements, considering the talent available in the local communities? How about insights on the quality of leadership capability within local pharmacies? Professor Babak, you want to comment on that briefly?
Yes, certainly. I think we have seen that in the past as well, that actually the leadership is really important, and the capable leaders can take things to a next level. And you could have fantastic leaders if they're good trailblazers and they're champions. They can really take things and they can really deliver. Especially in these settings where we're talking about innovative pharmacy services, when they have a lot of challenges, they need to prove to the health system, to the doctors, to healthcare professionals, to Ministry of Health. Then of course you need somebody who has these abilities, because if you have a fantastic program in place, you have funding in place, and if there is no appropriate person to guide in this regard, then it would be really it will be a challenging task.
Thank you very much. So somebody asks, will the pharmacy order the medicines from, in such a model, will the pharmacy order the medicines from government? And do the stocks remain government stocks? Or do they order it from a private wholesaler? I think the question has to do with the procurement side of things. So again, to our panelists, maybe Veronica can start, and then Dennis, you can share some examples on the procurement side.
That's an excellent question. Thank you for this question. In Europe, in the case studies that we have looked at, and as most of the participants will be aware of, the pharmacies procure their medicines from the wholesalers, from the distributors in the market. So it's not the government that does large purchases, and the pharmacies take advantage of these large purchases. The retail pharmacies themselves purchase the medicines. As was brought up by Dennis as an example in Uganda, that doesn't necessarily mean that the pharmacies, each of the retail pharmacies, have strong capacity to do good procurement. This has obviously an effect on the prices that they have to charge their customers to maintain profitability. So in the report, we talk about that specifically, and we also highlight some examples in which pharmacy service administrative organizations have been created that support pharmacies, retail pharmacies, in being smarter in procuring medicines. So these are examples that could be looked at much more in detail and evaluated, and seeing whether such kind of organizations of pharmacies coming together purchasing medicines is worthwhile pursuing, and in which context does it make sense to pursue such organizations. So I think much more work is necessary to develop models and sophisticate them, to propose in which context the models in which pharmacies come together to form, let's say, purchasing communities can work, and what are the market requirements for having these. So Dennis, over to you.
Yeah, thank you, Veronica. Just to agree that to ensure that the services offered by the private pharmacies are really cost effective, it requires, of course, bulk purchasing that then they can be able to tap into to provide services that are really affordable. But specifically to the case in Uganda currently for the ART program that is being scaled up and patients are accessing commodities from the pharmacies, These are commodities procured by government and procured also by donors, but channeled through the national government medical stores to the nearest facility to these private pharmacies. Now, these private pharmacies then routinely make orders and obtain these commodities from these facilities. So kind of the facilities get commodities on behalf of the pharmacies from the national medical stores. And the reporting also for these commodities go via these same facilities, I would say. So that's, I think, the contextual example here. But I completely agree that a model that allows for aggregation of pharmacies to come into associations that then do bulk procurements would be helpful. Another second example that we kind of have taken advantage of here, not directly for any contracting from government to the private pharmacies, is a network of private not-for-profit health facilities that through their medical bureaus have been able to establish what we call here a joint medical stores. They are really a huge player. They support a network of over 1,000 health facilities. Their prices are really affordable. Their quality assurance systems are good. And they are also open to the private sector for purchasing of commodities. So they've been very helpful in times of COVID-19, where really the supply chain was messed up. They've been very helpful in ensuring that these commodities reach the private sector, but also people who need them. So I think that's what I'll add. Thank you. Over to you, Kwesi.
So thank you. Clearly, for this model to work, we need some form of centralized purchasing, which could be private sector led or government led or the private not-for-profit model, but the key, it must be contextual and it must be able to influence the market, the value chain to ensure that pricing and others is properly affected. And I think we have good examples from the high-income countries. Sweden and others also had varied models. One other question that has come up from participants is that there seems to be a lack of partnership or, let's say, trust, between public systems and the private system. So one key challenge is that governments in Sub-Saharan Africa, governments in LMICs don't even recognize the community pharmacies as partners, in their healthcare architecture or ecosystem. The MOH know about the pharmacists or the pharmacies, but they view them, from a skewed perspective of business entities for profit only. Any general comments from any of the panelists? We could start with Veronica, and then any general comments from anyone?
Yeah,
How do we change that mindset?
Yes, you raise a very important point, which we bring out in the report as a critical one, which is thinking about pharmacies as commercial points, so sales of medicines, which traditionally is, I think, the views of many. It's the views of many clients, it's the views of many users. I see that as a commercial point. For instance, it brings sometimes mistrust, or it brings the perception that obviously one is talking to a salesman as the person behind the counter, not necessarily as someone counseling, providing advice, which, for instance, if you want to bring in more clinical services, more primary care services to private pharmacies, then that would need to change in terms of perspectives, the public payers' perspective, to see the private pharmacies really as an important service delivery point that is part of the health system and therefore comes with certain public health goals. And this requires shift in thinking of potentially of the public payers, of the pharmacy associations. What role do they play and want to play? And that needs to be reflected in their standards and their professional standards. And that also plays a role in the users and the user demand and the perception that users have of the services that are rendered. So that's a huge agenda. The reports pointed out and lays it out at different of the opportunities and challenges that we are talking about, but there's certainly a huge agenda to go forward and very, very critical point.
No, thank you. Professor Baba, if you have any comments on that, I would like you to highlight that, and in particular, give us some insights on whether this model will be for particular groups of people, or you see this model as being able to serve a wider population, in terms of dispensing and service delivery. Unfortunately, you're muted.
Yeah, sorry. I see it as both. I see that it could be used for particular groups. So for example, in this case, family planning products or other specific group of pharmaceuticals, whether it's for diabetes medicines or antihypertensive or any other sort of things, or it could be used generic in both cases. But I think, as Veronica has rightly pointed out, a public health message needs to be embedded, and maybe a sort of a promotional campaign or a public health sort of an agenda where the government, through maybe a public-private partnership or in some other ways, could promote this message. Because community pharmacies all over the world, they are seen more sort of as a commercial entities, and this is a challenge not only in low and middle income countries, but so for also in high income countries. There was a survey a few years ago in the UK where only it was observed that only 10% of the consumers, or even less than 10%, they actually sort of see community pharmacy as a sort of more sort of a healthcare professional entity or an exercise. So I think in the context of low and middle income countries, this message needs to be clear, and it has to come through public health promotional campaigns, where the policy impact, the health outcomes or patient outcomes impact could be strengthened in this area.
All right. So as we round up, I just want to give the panelists an opportunity, including Veronica. What in your mind, from where you said are the potential next steps, both at the global and the national level, to move this discussion forward, a thought leadership paper, and then the concept of implementing, outsourcing of services to the private pharmacies. I would like to start with Denise, if you have any thoughts on the potential next steps.
Sure, I'll be really brief so others can speak. I think I've stated before, I do think some piloting and implementation would be the next steps, really working with countries and ministries of health, and USAID missions that have already taken the step or want to take these steps or are doing it. So I think that's the next step. Continuing to gather, information and data is important. And also to your other question, I just want to emphasize, when it comes to trust, I do think that's where you have blockchain and NFTs that can build this trust between the two sectors. If the two sectors aren't interacting or working together, we're not really serving the population. One sector cannot do it on its own. Thank you. Over.
Thank you. Dennis?
Yeah, thank you. 3 takeaways for me as logical next steps. One, I think we need to work towards advocacy for stronger and more inclusive regulation to incorporate this very exciting opportunity that will help improve access for commodities. The second is, given the context where we stand, it would be important to probably take this in steps. So there could be need to define a basic pack of medicines that we could then start to move with this approach, looking at the disease burden and demographics of these countries that could actually solve a bit of the top 10 disease burden for commodities. And then the last one, given the real big scope of services provided by the private sector, I think there would be need to also think about separating prescribing and dispensing, because we are looking at government, but 40% of our current services are provided in the private sector, where these two are really not separated. So I think that's an important perspective I wanted to bring. Thank you.
Thank you. Professor Baba?
Yeah, I think need to have some generic lessons and see what could be the synthesis from this which could apply it in all setting, in all spectrum of countries, whether it's continuing education, whether it's pharmaceutical systems, whether these are related to procurement. So I would see the next step forward is actually more sort of a synthesis and more analysis from the report towards some generic things which could be highlighted and further work on that. And what could those be? I can't really comment on that, but 3 or 4 major.
Thank you very much. Veronica?
Yeah, just very, very briefly, I would like to thank everybody on the panel for their great summaries, and couldn't agree more with many of the points mentioned. I think a standing task force, a group of experts that would devote time to continuously work on such subject and pushing forward the agenda, multi-stakeholder group, I think is extremely relevant. In addition to what was mentioned, like evaluation of some of the cases, country cases that we have seen gone forward, and taking these lessons learned and use them for developing a roadmap for going forward. Thank you.
Thank you so much, all our panelists, and thank you so much for all the insights. I'd like to hand over to Kevin to give us the closing remarks, and thanks all for staying in with us. Kevin, over to you, Kevin.
Yeah, thanks very much. I know time has ended, but just say what a rich discussion. I certainly have learned a lot, both from the panel and the presentation, but also from the chat. So thanks to everyone who participated. Big thanks to all of our presenters and panelists. It's a lot more to be done, as we've all talked about. So we as USAID certainly will keep the conversation going, and we appreciate everyone's inputs and hope to continue receiving those inputs. So have a great afternoon and great evening, everybody.
All right.